Precautions on our hands that we should clean. For our patients and our health, here are a few steps. If you complete, you're the best. Alcohol sanitizer will do. A few pumps, rub it up on the left arm and the right. Press your fingers together as you contemplate the weather. Clean hands are good for everyone. Now a thumb, then the other one. We're on the last step from the end. Press your fingers together as you rub your palms forever. Hands will dry as you end up our song.
When to wash your hands. Before touching a patient. Before a clean or an aseptic procedure. After a body fluid exposure risk. After touching a patient. After touching a patient's surroundings.
Good morning, my name is Danovan Reiters. I'm a first year medical student at Stellenbosch University. Can I please confirm your name?
Well, my name is Daniel Mufulisa.
Nice to meet you, Daniel. Daniel, today I would like to do a respiratory examination. This will involve me standing at the foot of the bed, touching your chest at different areas, and also using a stethoscope at the end. Is that fine with you?
That's fine, sir.
Okay, Daniel, I would really ask you to just be comfortable with this examination, and then I would like you to just put your legs on top here.
Okay.
And then just take off your shirt, please. So this bed is placed at a 45-degree angle for respiratory examination. And also we ensure that there's sufficient lighting. Okay, you may lay down like that. Thank you, Daniel. Okay, so I'm going to move to the foot of the bed for 30 seconds just to do the respiratory examination. Okay, so I'm going to move to the foot of the bed. From the moment I saw the patient, I could see that the patient is not in any respiratory distress. This would entail flaring of the nostrils, breathing with an open mouth, and this will also involve him using accessory muscles and producing the production of sounds like wheezing and coughing. Also, very important, my patient's rate, rhythm, and depth of breath is normal. Also, his breathing per minute was between 12 and 20, which indicates that it's normal. Thank you so much, Daniel.
May I please get your consent to examine? Okay. Firstly, I'll start off with examining your hands. Will you please present them to me? Okay. Thank you very much. Upon inspection, I found that there's no blue discoloration of the nails, indicative of cyanosis. They are also not pale, indicative of anemia. Will you please turn your hands around for me? The palmar creases are normal, and thus the patient is not Down syndrome. There is no nicotine staining on the fingers, and the first webbing on both hands also does not display nicotine staining, which would be indicative of a smoker. Okay, can you please bring your fingers together for me, such as displayed? Upon inspection, I found that the diamond gap is present when the patient brings his two fingers together. This rules out clubbing, which is caused by infected endocarditis, lung disease, liver cirrhosis, and bowel diseases. This is when soft tissue builds up on the distal parts of fingers and toes, causing sponginess. The next thing is I will be inspecting the patient's body temperature. Can you please extend your arms out in front of you for me? Upon inspection, I have found that the patient's body temperature is normal. Can you please raise your arms again for me? And flex your wrists backwards while opening your fingers. No flapping tremor is present, which would be indicative of carbon dioxide retention and COPD. May I please take your radial pulse? Upon inspection, I found that the patient's radial pulse falls within the norm, which is 60 to 100 beats per minute. This is very important for a clinician to do to establish whether the patient is experiencing bradycardia or tachycardia, which is a large contributing factor to asthmatic patients.
May I please get consent to examine you? So I'm going to start by looking at your face and neck. Can you please come forward? Okay. You have to raise your neck just like a quad. Okay, thank you. So right now I'm looking for signs of hypoxia as well as wasting in the temporal regions and the cheekbones. None of that is present. If you look at the sclera, they're the correct color. If they were yellowish, this would indicate jaundice, which is caused by raised bilirubin levels. I'm now going to pull down on your lower eyelid, okay? So if you look at the conjunctiva, they're nice and pink in color. If they were white, this would indicate anemia. And if they were reddish in color, this would indicate polycythemia, which is when there's a hemoglobin level that exceeds what is considered normal for the age and sex of the person. Can you please open your mouth? And then raise your tongue towards the palate. Okay, thank you. Now I'm looking for bluish discoloration on the sides and tips of the tongue to indicate central cyanosis. None of that was present. And then if you look at the buccal mucosa, it's the correct color. If there was a yellowish discoloration, this would indicate jaundice. And now I'm going to press down on your ankles for a few seconds to check for edema. So what I'm going to do now is press on your ankles for 10 seconds to see if there's edema. Edema is caused by fluid retention or excessive accumulation of fluid. After the pressure is released, no indentation remains on the ankles, meaning that there's no edema present. So I'm now going to examine your lymph nodes to check for systemic illness. Is that okay? Do you mind swinging over the bed and sitting upright? Thank you. So we're starting off with the pre-auricular lymph nodes, then moving to the posterior auricular behind the ear. Then I'm palpating along the occipital lymph nodes. I'm moving to the tonsillar, submaxillary, and then submental below the chin. Using the sternocleidomastoid mastoid muscle as a guide, we're going to do the superficial cervical chain, the posterior cervical chain, and then lastly, the anterior cervical chain. Then we're going to move down to, using the clavicles, we're moving down to the supraclavicular, and then the infraclavicular. Okay, so none of your lymph nodes were palpable, meaning that there are no signs of systemic illness.
I'm now going to do an inspection of the chest to see whether the expansion is normal. Do I have consent to continue? First of all, the patient needs to be in a 45-degree angle with the chest exposed from the waist upwards. I inspect the chest and I see that there are no signs of scars or lesions or any areas of irritation. His hair distribution and color is also normal. I'm now going to look at the dimensions of the chest. The normal adult chest is twice as wide as what it is deep. That's 1, that's 2, that's 1. Okay. I'm now going to look at the expansion of the upper lobes. I do this by standing behind the patient and looking at the clavicles as he takes a deep breath in. Please take a deep breath. Okay, and out. By looking at the clavicles, I can see that both the upper lobes are expanding normally and symmetrically. I'm now going to stand at the foot of the bed and look at the lower lobes. Please take a deep breath in and out. Both lower lobes are expanding normally and symmetrically.
Do you have permission to touch your chest?
That's fine.
Thank you. Alright, so before I start, I'm just going to apply pressure to your chest. I would like you to tell me if you experience any tenderness. No tenderness? Alright, the patient seems to express no signs of tenderness. There seems to be no underlying fractures or underlying masses. Okay, so we're going to be using the landmarks of the clavicle heads, the scapula for the posterior parts, and the trachea, the sternocleidomastoid muscles. So if you just look to the sides, there, and then to the side, to your left, there. Alright, so I'm going to place my 2 fingers on the heads of your clavicles, and I'm going to gently glide my middle finger up to identify your tracheal rings. I'm going to slide my finger in between the space of the trachea and the sternocleidomastoid muscle. Alright. The spaces seem to be even, which says that the trachea is in the central position, which is normal. It would also have been normal if it were to be slightly deviated to the right. Okay. Alright, the next thing I'm going to do is I'm going to examine your chest expansion. Okay, so I'm going to place my hands on the lateral aspects of your anterior chest, and I'm just going to make my thumbs meet in the middle of where your xiphoid process is. Okay, I'm going to ask you to breathe in very deeply through an open mouth. You're going to do that 3 times.
Okay.
All right. All right. Thank you. The patient's chest expansion seems to be within the normal range of 5 to 8 centimeters. The chest expansion is normal and it's symmetrical. Alright, the last thing I'm going to do is I'm going to examine your vocal fermenters. So I'm going to do that by placing my palms through the zones of your chest, the upper, the mid, and the lower zones. While I'm doing this, I'm going to ask you to say the words 99. Once again, if you experience any tenderness, just let me know. Alright.
99, 99, 99.
Thank you. The patient's vocal fermenters, there was no increase in vocal fermenters, and the vocal fermenters were symmetrical.
If you don't mind, can you please straddle the bed? Thank you. So if it is okay with you, I'm going to be gently placing my hands on your back, and you tell me if you're experiencing any tenderness. Okay, there seems to be no underlying masses or any fractures towards his ribcage. For the next portion of your exam, I'm going to be placing my hands below your scapula and I'm going to ask you to breathe in and out through your mouth. Breathe in. Again. The last one. Thank you. So, the expansion of the chest seems to be between 3 and 5 centimeters, which is normal for the posterior end, and the breathing seems to be symmetrical on the right side and on the left side. So for the next portion of the exam, I'm going to be placing my hands down your back, and I'm going to need you to say 99 each time. So for the upper region,
99,
the mid,
99,
and the lower.
99.
The vocal fremitus seems to be equal on both sides, so it's symmetrical, and there is no increased fremitus on either end.
So I'll be performing a technique called percussion. So that just involves me tapping along the chest in a couple of areas, and it includes the space between the ribs, so that's the intercostal space. To the right hand side and the left hand side, and yourself.
Yes, you may.
Okay. Thank you. I'm going to start with the supraclavicular fossa. So resonate. Resonate. And percuss directly onto the clavicles. Resonate. Resonate. Then we move from the sternal notch down to the sternal angle to find the second rib. And below that, the second intercostal space. It's resonant. On the right hand side, the second intercostal space. Resonant. Third intercostal space on the right. Resonant. Third intercostal space on the left hand side. Resonant. Fourth intercostal space on the left hand side. And still, and that's because of cardiac dullness. Fourth intercostal space on the right hand side. Resonant. Fifth intercostal space on the right hand side. Resonant. Fifth intercostal space on the left hand side. Resonant. Sixth intercostal space on the left hand side. Resonant. Sixth intercostal space on the right hand side. Dullness, so that's liver dullness. And now I'm going to move on to the axillary region. So if you could lift up your left hand for me. This is the anterior axillary line, the mid axillary line, and then the posterior axillary line. I'm going to cuss over there. Isn't it? Understand for me? That is liver dullness. Isn't it? Isn't it? Thank you so much.
Good day.
Hi.
My name is Amira Parker. I'm a first year medical student and I'm going to be percussing on the posterior region. And basically what this means is I'm going to be tapping on your back just to see what things fine. May I proceed?
Yes, you may. Thanks.
Could you please sit with your legs hanging over?
All right. What goes right?
And then could you cross your arms over your chest and your neck being downwards. So I'm going to use C7 as a landmark and I'm going to percuss close to the spine on either side. Resonant. 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 And resonant. And now I'm going to percuss on the posterior sides of the lateral axilla. Resonant. And resonant. Thank you very much.
May I also take your anterior chest? It basically just entails me listening to your chest sounds with my stethoscope. Everything I do on the right side, I will repeat on the left. I've identified the sternal notch, the sternal head, the clavicle, the midclavicular line, and I will now proceed to auscultate the supraclavicular fossas with the bell side of my stethoscope. Every time I place my stethoscope on your chest, will you please take a deep breath in and out through an open mouth. Now, switching to the diaphragm side of my stethoscope, I will proceed to auscultate the intercostal spaces. I've identified the sternum, the angle of Louis, and laterally to that you will find the second rib, which will help you locate the second intercostal space. I will now proceed to auscultate the medial line of the axilla.
deep breath in and out. During the auscultation, all the breathing was symmetrical, and I heard vesicular breathing, which is when inspiration lasts longer than expiration with no gap in between, and it sounds like the rustling of leaves. In abnormal cases, bronchial breathing may be heard. It is when expiration and inspiration is more or less the same, with a gap in between, and it's a quite hollow, high-pitched sound. No crepitations or wheezing was heard. So essentially what I'm going to be doing today is vocal resonance. That is just me placing the stethoscope on different areas of your chest and just listening to you when you speak. May I proceed?
Yes, ma'am.
Alright, so we're going to start in the supraclavicular fossa of the patient, and for that you use the bell of your stethoscope. So when I place the stethoscope on your chest, please just say 99. So we're starting on the right supraclavicular fossa,
99.
on the left supraclavicular fossa,
99.
and then we're going for the rest of the chest examination. We will be switching the stethoscope to the diaphragm. So we're starting on the upper zone,
99.
going to the right upper zone,
99.
going down to the mid zone,
99.
going across to the left mid zone,
99.
going down to the lower zone,
99.
going across to the right lower zone.
99.
We'll also be examining the axillary midline. So we're going on the right axillary line,
99.
going to the left axillary line,
99.
going down the axillary line,
99.
going down the right axillary line.
99.
So the vocal resonance is normal and symmetrical, and there's no increase in resonance, which means that there's no consolidation. Thank you so much.
Today I'm going to perform a procedure called auscultation of your posterior chest, which is basically me just examining your breathing sounds with my stethoscope at different positions of your back. May I please perform this procedure? Thank you very much. Now that I've obtained consent, verbal consent from the patient, I will continue with my auscultation of the posterior chest. During the auscultation, I'll be listening to breathing sound quality, which refers to the sound that is produced while air moves into the lungs. It can either be vesicular, bronchial, or even amorphic, which is a very exaggerated hollow sound. Further, I will be noting any adventitious or added sounds, and also I will be listening to breathing sound intensity, which refers to the movement of air into the lungs that can either be normal, reduced, or absent. Next, I will ask the patient to please sit up straight, and can you please straddle the bed, sir? Thank you very much. Can you give yourself a hug and look down? Thanks. We do this to expose as much of the posterior chest wall as possible to aid in auscultation. I will now identify my landmarks, which would be the spinal cord, which functions as our midline, specifically noting the 7th cervical vertebrae, which will indicate the level where I need to start my auscultation, about 2 to 3 centimeters lateral to the midline. I will also note the scapulae, which will indicate the contours that I need to follow during the auscultation. So sir, during this procedure, can I please ask you to take a deep, slow breath in through your mouth and then out again. Okay, thank you very much. I will now identify my first position. Yes, sir, tilt your head forwards. Thank you. Take a deep breath in. All right, thank you very much, sir. You can relax. During my auscultation, I noted that the breathing sound quality was bronchial, close to the top, which is normal, and as we moved down, it turned into vesicular breathing. The breathing was also symmetrical as I compared both sides and there were no changes. I also noted that the breathing sound intensity was normal throughout, and there were no adventitious or added sounds like crepitations, wheezing, or a pleural rub. Thank you very much.
Okay, sir. Today we're going to do your posterior vocal resonance, which requires me to auscultate your back. And then this is to check whether you have a normal lung or a consolidated lung. Can you please show me your back, hug yourself, and move to the side. Okay. So as I'll be doing this, can you please confirm by saying 99? Okay. 99. 99. 99. 99. 99. 99. Okay, sir, from my observation, it seems that you have a normal lung because I had a muffled sound coming from your lungs. So if it was consolidated, it would have been a clear sound coming from this lung. So that concludes our examination. Thank you, sir.